Welcome everybody. Nice to see you all. We've had the pleasure of doing these webinars with people of physicians of different domain expertise. Last time we had the opportunity to do a webinar between the junction of sleep and dentistry and airway, and we had Dr. Zubiak and Dr. Carson on the show. And today we have Dr. Kagen, who's become a dear friend of mine. He's a internist, a concierge physician in Park City, Utah. He does all sorts of cool stuff. And there's a big relationship between sleep disorders and sleep disorders that are prevalent in the primary care setting. And the goal of sort of today's conversation is to really understand in a primary care setting how Dr. Kagen is sort of looking at sleep, how he's addressing it, what are some of the things that he's looking for. He also has a separate startup that he's working on that has to do with data. And so we'll get to hear from him about that. And he also works with athletes. So we'll get to hear a little bit about how he's helping athletes improve their overall function through his practice. Dr. Kagen, thanks for being here. Pleasure to chat with you again.
Yeah, thank you. Thank you for having me. Yeah, I'm the founder and CEO of YOMI Health and KagenMD, located here in Park City, Utah. And thanks for having me on today.
Absolutely. Oh, sorry, let me go ahead and mute all of these notifications here. Mike, you and I have spoken, quite a bit now, both through text and phone. I have a reasonable understanding of all the cool things that you're up to, but I'd love to hear like how you sort of end up in Park City doing what you do on a daily basis.
Okay. Yeah. After I finished my training in internal medicine, I practiced in a large outpatient setting where, it's high volume practice, where it was part of a carnival care organization. I figured out very early on that that's not the right kind of model for internal medicine. And I looked at the membership models, and that looked very, very appealing. So it was just a matter of like where I was going to go to start a practice. But I had friends from, I used to be a former speed skater long time ago. I'm no longer involved in the sport as an athlete. But I had friends that had lived out in Park City, Utah back for the 2002 Olympic Winter Games, where they were doing the Live High and Train Low program. And I've been hearing wonderful things about Utah for my entire life, and finally made it out to Utah, and we decided to settle here and open up shop and live and play here. So that's what we do.
That's awesome. And you moved to Utah when?
2017.
17. And you transitioned from a traditional model practice to a concierge DPC model, or were you doing this concierge DPC model back where you were prior?
It was a straight insurance model that I was practicing with before. And I moved locations and started just fresh with a brand new membership practice.
Wow. And tell me more. I mean, I feel like having not done something before and then sort of jumping into it, that too in a new city, it sounds like a pretty challenging endeavor. Like where did you even start, and how did you sort of come up with everything that you've sort of built up to today?
That's a great question. It's a lot of work to get a practice started, and it takes a lot of time to build up a practice to its capacity. But I just started renting space and saying I'm open up for internal medicine, and there's a need most places in most cities in the United States. Just the way that the insurance model is, most people are looking for something different than the sick care system. So our practice really focuses on preventative, proactive kind of medical care. So we want to increase people's productivity and extend longevity and keep people healthy. So a lot of people are interested in that kind of model of medicine.
Yeah, no, Peter Attia's book Outlive has become extremely popular, like in the last few months, and I've become a big fan of it. And he talks about this idea of like healthcare 3.0, and we've sort of adopted that in what we're doing and saying like we want to practice at least. I mean, I don't have the capacity to practice healthcare 3.0, but at least we can do sleep care 3.0. That is like hyper personalized, risk stratified, and really meeting the patient where they are rather than following traditional guidelines where X equals X, X equals Y, and then just like having a sort of like a blanket way of a cookie cutter way of like of taking care of people. So I love this like membership based model that's personalized and really driving outcomes, driving prevention, disease prevention, and meeting where people are. You mentioned that you work with athletes too.
Yeah, that's right. We live in a very active community. So most people that live where I'm living in Utah are active on a daily basis. I also volunteer as a team physician for the U.S. speed skating team. So I work with a lot of Olympic level athletes. So most people in my practice are very active, and then there's the hyperactive where they're training 8 hours a day and staying extremely fit.
Yeah. And what are some of the, I'm just curious, when you're trying to help an athlete break like a specific kind of a ceiling, whether that's time or running, or whatever that may be, and I'm sure it's different for everybody. How does that typically work from like a healthcare stand? Like, even though it's not purely healthcare, but like how would love to learn a little bit about how you're helping them sort of do that.
One of the biggest things with athletes is maximizing their productive days. So that's a matter of detecting overtraining and also early signs of illness so that we can catch that as early as possible so that they can do the most amount of work longer term. So it might be backing them off at the right time so that they can recover, either muscle recovery, or if it's early signs of illness, that they get over the illness very quickly. And then ultimately they can do the most amount of work to get fit. So that's
Yeah,
that's
it's
the
interesting.
the biggest thing. Yeah, most of the athletes don't
Very,
have any issues with sleep per se. It's more of an issue of detecting overtraining or illness. Those are the
yeah,
major ones.
yeah, that makes complete sense. And you sort of like talked about sleep. When it comes to sleep and athletes, I know like LeBron James, he makes sure that he gets his 7 to 9 hours of sleep. Um, when you're working with these athletes that you're working with, how does that conversation typically look like? Sleep. When we think about sleep, we think about it from the standpoint of like, what's the quality of their sleep, what's the duration of their sleep, and what's the timing of their sleep. The duration is like this sort of comes from population statistics of 7 to 9 hours. The timing should be sort of circadian in nature, meaning that like that individual should be sleeping during their biologic night rather than sleeping during their biologic day. And then the idea of sleep quality is making sure that that sleep that they are consuming is free of disease. So it should be free of like a lot of fragmentation. It should be free of things that cause a reduction in deep sleep. It should be free of things like disorders like restless legs, periodic limb movements, and sleep apnea. And in these athletes, when like the quality is probably very good, I would imagine.
Yes.
The is it like really much the duration and the timing that you're helping them focus on?
I mean, that's definitely a big factor when they're traveling, like traveling internationally, like that can become a big disruptor to their training. But most athletes have a very regular training program. So they're going to bed at the same time, they're getting up at the same time. They're tired from all the work that they're doing. So they're usually getting to sleep really, really well. And then it's a matter of just kind of taking a look at the data during their sleep of how fast they're getting down to their lowest resting heart rate, and looking at signs of recovery.
Mm, interesting. Have you ever tested these patients? I'm just curious what they're.
Not with a home sleep test, but just looking at like wearable information. We'll take a look at that and
It
dive
would be
in.
it would be really interesting to see that. The other thing that just comes to mind is this idea of melatonin profiling, where you can profile someone's body clock with the ability to check. So melatonin is the hormone of the night, and based off of what the peak and trough of melatonin is, we can understand what is that individual's biologic night and what is their biologic day. Even to the point of like when does that biologic night start, between what hours to what hours, and when does that biologic night end, between say 7 a.m. and 9 a.m. And if one can understand that, that can also be very useful information, I would imagine, to help these people like optimize their circadian rhythm, chronobiology, and also like when they already have very, very healthy sleep. So that'd be interesting to look at. I think we should jump on a separate call to discuss that in the future.
Yeah, that sounds really interesting. So how is that measured? Is it like you do a blood test at a certain time of day, or a series of blood tests?
It's actually a series of salivary tests, and
Hmm.
it can be either a 6 sample or a 9 sample. That's the usual. And you have the patient spit into a little container every 3 to 6 hours, depending on the number of samples, over a 24-hour period.
Hmm.
And basically, what you end up with is like a graph, like a graph that has a peak and a trough. And when it is the peak, you can see, okay, during this window is when is this individual's biologic night, and during the trough is this individual's biologic day. And we do that often for people who have circadian rhythm disorders, and you don't know like where their night is and where their day is because they're snacking on sleep during the day and they can't sleep during the night, or maybe they're sleeping a little bit in the middle of the night. And you're just really confused on what's this individual's nighttime and what's this individual's daytime. And that can be a super useful test to then understand that, because body clocks can move in either direction. They can be pushed forward or they can be pushed backward. Like jet lag is an example.
Hmm.
Acclimatizing to jet lag is an example of our body clock shifting in the direction that we want it to shift. So in these people where you do have no idea what's their day and what's their night, doing a melatonin profile can be super helpful.
Yeah, interesting.
Yeah. Interesting. With your, traditional patients that you're taking care of in this like membership based model, is sleep is something I would imagine is important. Nutrition is something that I would imagine is very important.
Hmm.
Exercise these are all sort of like the foundations of one's overall well-being, especially in a preventative care model. um I would love to hear your thoughts on like what sleep looks like, and how do you sort of have that conversation, and what do you typically do when you're having these conversations?
Well, a lot of it is history taking of how people are feeling throughout the day. Like, asking people how they feel when they wake up in the morning, how are they feeling in the early afternoon, and again, like really maximizing like how can they have the most productive day possible. And that's where we're really going to dive into how are they sleeping. I mean, that's part of the holistic view of someone is all the things that you just mentioned, plus the social aspect, how much time they're spending with friends and family, and just being happy. That's all very, very important. And sleep is about a third of your life, so it has to be good quality sleep to be able to feel good. And I think most people just know this intuitively. If they don't get a good night's rest, they're not going to have a very productive day the next day. So we want to make sure they're having very good quality sleep at the right time so that they can do the most throughout the day. It's not always a secondary workup where we're looking at, why is the blood pressure staying high and we're on several medications, about, looking for obstructive sleep apnea. A lot of times I'll do sleep tests sort of proactively, just based on how someone's sleeping. If they feel like their sleep is just not great, or they just want to dive into some data and see what's happening during the night, that's very helpful. It's also, I found it really interesting to be comparing the wearable devices to a home sleep test, and seeing how things measure up. And you and I have had some discussions about this as well. And I think a lot of people are under the impression with some of the at-home consumable devices that their oxygen's being measured every second, where it's really not. Like you wouldn't be able to look at certain devices and say, oh, my oxygen was great throughout the night. It's not really true. So a home sleep test can a lot of times shed a lot of new information into the light.
Yeah, no, for sure. I mean, you just touched upon many different things, but this idea of doing a um, pr prophylactic sleep test, or sort of just we call it a sleep health assessment. Like, I'm just curious to know, what is the health of your sleep? We do this for cardiac function, like, we do this for colonoscopies. When someone hits a certain age, like, what's the health of your, let's just make sure, let's do a screening colonoscopy, make sure there's no malignancies. um, Many people, even in the absence of risk factors, but as they get older, they may end up getting a stress test or a coronary calcium score done, just to
Mhm.
see what's the health of their coronaries. And we many times talk about like a sleep test as like, this is more of like a sleep health assessment. Let's just set aside some time to see what is the health of your overall sleep like. Is it physiologic, meaning, um, for your age, a healthy individual should have like this kind of sleep architecture, or this distribution of deep sleep, REM sleep, and light sleep. And where are you today? And where were you, say, a decade ago? Is that decline in the quality of sleep uh, the same as for most people, or is your sleep declining more rapidly than like the traditional mean of
Mhm.
individual? And I think, people have been kind of doing this for, like, say, cognition. Like, what is, like, is your cognition relatively stable for a healthy 50-year-old? And is that rate of decline that we know that is going to happen when you are 60, is it where it should be, or is that rate of decline much faster? So I think, like, this idea of just doing a sleep health examination is like super important. And it has not been done in the past, I think, because uh, sleep testing has been primarily isolated to sleep labs. And sleep
Mhm.
labs historically have been densely placed in larger cities. And these labs may operate with three, usually in, digits of three, 6 or 9 or 12 beds. And it's just like not a scalable model. So only when someone is suffering from a pathologic problem is when they end up in a sleep lab. But as you've seen, like, doing sleep tests nowadays is so easy that I don't think we're far from where we would just be doing like a sleep test every 10 years, just as a part of like a general sleep, just as a part of a general assessment, and just with the idea of like, let me test the overall health of your sleep. I think that that's probably coming. Um, and that's typically how we, talk about it with our patients.
Yeah. I mean, I think you brought up a really good point about the access to the information, right? So it used to be the case, I don't know how many years ago, like when did home sleep tests become popularized? Maybe in the last 7 years?
No, maybe I think about a decade ago, and
Okay.
it was driven primarily by payers, rather than, like, there was a push of not to reimburse lab studies, and that's what pushed people to get a home sleep test. But had payers continued to push, had payers continued to pay for in-lab studies, the system was naturally incentivized to send people to a lab. But the second Medicare said, hey, I think for this kind of criteria, these kinds of individuals, a home sleep test is adequate, and we won't reimburse for an in-lab study anymore. That is what pushed a lot of people to start getting home sleep testing, and it just sort of opened up this window of opportunity to help people, assess their sleep.
Yeah. I think the access for an in-lab sleep study, it's usually probably 3 to 6 months out. I haven't tried at all recently, but that's generally the case where it's not really accessible. And it just seems peculiar to me as well to have someone sleep in a foreign environment to see what their sleep looks like. Like no one's going to sleep well in a hospital. Just
Yeah.
doesn't seem like the right approach.
Yeah, no, definitely. And that makes complete sense. And we've kind of known that, but historically there wasn't very many options. And you just did the best, one just did the best that they could. But with the invention of like modern sensors and technology, it's really exciting to be able to get multiple nights of data from the comfort of their home and allowing them to like experiment with what is serving their sleep health and what is destroying their sleep health. And I think it's really powerful.
Right. Another thing too is the willingness of someone to use a sleep prescription, like especially if it's some kind of PAP therapy, positive airway pressure. People generally don't want to wear a mask on their face at night, and if they can see a good reason to do it, and you and I have worked on this recently of acquiring data, on and off a mask or at higher elevation or lower elevation. I mean, many of the members of my practice sleep between 6,000 and 10,000 feet. So seeing the changes with elevation is very helpful, and getting more data. So if we have 2 weeks of data and we can see what happens with or without certain interventions, there's a lot of information that can be interpreted from that.
Yeah, I know for sure. I mean, that's kind of exactly why we do what we do and like how we think about solving problems. You'll be surprised. I've actually taken people off of CPAP because through longitudinal data and analysis, one can understand objectively and subjectively that this individual has the same quality of sleep with, say, lip tape and a nose dilator that helps promote nasal breathing and less airway collapsibility as compared to a low pressure of CPAP. And that's so powerful because now you don't have to like take this bulky thing with you everywhere you go. And your sleep can be your sleep stack of which we call it a sleep stack, a series of interventions that when combined appropriately, they will help you have the most optimal sleep. And with this sort of stack of interventions, your sleep is the same as it is with this. And patients love it. And we've been able to compare dental appliances to CPAP, dental appliances and CPAP combined. We've been able to look at sort of INAP. It's like a little suction device that brings the tongue forward to create more space in the back of the throat.
Hmm.
And now we can actually be precise with the intervention that we're doing. And it's not just this idea of insomnia equals a sedative and sleep apnea equals CPAP. It's rather um, insomnia can equal all of these, like a series of permutations of all of these different interventions. And sleep apnea can equal all of the multiple permutations of all of these different interventions. And when you have this longitudinal data, you can really be precise with what we're doing. I mean, I just saw a patient 2 weeks ago. He had like an apnea index on his diagnostic run of we do like 7 to 10 nights of testing in the beginning to get a true trend and a true baseline. And he had 70 to 90 pauses in breathing per hour. We put him on PAP, and all of this was done remotely. We put him on CPAP. It dropped substantially. He was using a mask that was working for him, but like there was still residual disease. And after we modified the mask to something else, his sleep looks almost physiologic. And like nobody would have, imagined that someone like this could get to a sleep like this. And what was the unlocking factor was like that mask.
Hmm.
Or we had patients that we've talked about this before, like they're at altitude and you prescribe them Diamox to help stabilize breathing, or you can use sort of a non-vented mask, or if you combine CPAP plus a side sleeping pillow, plus maybe a couple of other things, you can help somebody really unlock, like you can break the ceiling of what was presumably feeling okay, but now it's like feeling excellent because you know what's the right solution for that individual. So it's been a lot of fun. It's been it's made it really exciting to run these experiments. And I feel like a fellow again of like just learning and trying to peel the onion and trying to figure out what's going on and helping this person sort of optimize these numbers. So it's been phenomenal.
Yeah,
Um, what are some of the problems like that you run into when it comes to caring for these people who have sleep issues?
I mean, so if someone has a sleep disorder, one of the biggest issues is, and I think this is with a lot of specialty care, it's access to the specialist, and it's like being available when they're available. So it's it's the convenience of having an appointment right away, having the right kind of follow up, having just very good customer service. Those are generally the major issues, and um, you know luckily we found you have a great service and Empower Sleep, so we appreciate everything that you guys are doing. And to what you were saying earlier about when people are prescribed hypnotics for sleep, one of the first things you want to do if someone's not sleeping well is do diagnostics, find out why someone's sleeping well. And I think most people don't want to be taking a medication, whether it's blood pressure medication or a hypnotic to go to sleep at night. And so doing the investigation, finding out actually what's going on really makes a whole lot of sense to then, you have to diagnose the problem accurately to be able to treat it appropriately. So if someone has obstructive sleep apnea, giving them a hypnotic is not going to do them any favors.
Yeah, no, for sure. I'm just reminded of like so many times I've taken people off of sedatives or hypnotics
Mhm.
because you do a sleep test for them on that sedative and then you take it off or you wean it down and you then show the patient the data like, hey, you actually are sleeping just fine. Like your sleep is not as bad as you thought it was. And and when they see that data, it's like, oh wow, you're right. I like okay, like if you say so and like the data suggests that I'm sleeping, then the willingness to taper off of these medicines becomes much higher. But when they don't have that data, the willingness to come off of medications is much lower. And I've also actually seen it go the other way, where the person was subjectively feeling relatively okay, and you do a sleep test, and uh, you discover that the quality of sleep is not all that amazing, and then that leads to problems too. So it's like it's definitely like a double-edged sword, and it can go either way. But we've been lucky in the sense that when we use it to help people, having this data can be super fruitful. And also, um, if they need to be on a sedative or hypnotic, what's the lowest effective dose of that medication? Because some people might be on a much higher dose of trazodone or any or Z-drug or Belsam or any of these, medications, and maybe they just need half of that dose. And with half of that dose, the effectiveness of that medication is still relatively the same, and they have less adverse effects.
Um, I don't know if this is where you wanted to go or not, but I'm just wondering which hypnotics are the most troublesome to come off of in your experience.
Hmm. I don't have anything in specific that comes to mind, but traditionally, benzos are a little bit harder to come off of than the Z drugs. Um, Trazodone, not so much. Mirtazapine and all of these other ones, not so much. But if I had to pick one drug, I would say benzos are a probably the more challenging one to come off of. And yeah, like that would be those would be my thoughts. Is there one that you've had a hard, like a specific one that you've had a tough time getting people off of?
Um, benzos and Z drugs, zolpidem in particular, I feel like is a real problem. Try to never use it. I'm sure there are situations where it has its use, but lot of issues with those medications.
Yeah. I mean, one of the things that we've been doing a lot now that we can test people on a therapeutic intervention is just see what their sleep is like with that medication. So
Hmm.
it's not uncommon for us to prescribe, say, a Z drug, a low dose or a higher dose for a week and see what does this individual sleep like. Does it get better subjectively? Does it get better objectively? And if it does get better objectively and it was very poor to begin with, as we think about like this idea of sleep care 3.0, that is risk stratification and personalization, then maybe this individual is better off on this medication than they would be if they were not on a medication, because we know that when people don't sleep, that's also detrimental.
Hmm.
But perhaps because this individual is sleeping better, his overall health span and lifespan might be better because the brain is sleeping. It is getting the restorative properties of deep sleep, which is, a necessity. So I think one can be more mindful with these, like with making these decisions when you have data like this. So we've been pretty open. I've been very open about prescribing them when required.
Hmm.
Do you have any specific resources? I know you mentioned that we've been working very closely to take care of these patients, but is there any other resources that um, you like sharing with patients? Any books on sleep? Any other resources on sleep that patients have found very useful?
Um, Not really any that come to mind. I mean, it's generally pretty basic, recommendations about just good sleep hygiene, that tends to work for vast majority of people.
Yeah, yeah, yeah. I know we will typically, tell people to have a fixed wake up time to start off with, maybe a flux of 30 minutes. It could be, weekdays and weekends. Try to keep it as consistent as possible. Try to get adequate sunlight upon awakening for at least 20 to 30 minutes. Um, stop drinking caffeine after noon if you can.
Mhm.
Avoid taking naps if you can. If you need to take a nap, that's a different, I think, conversation. And then in the evening time, try to eat 3 hours or so before your habitual sleep time. You want to stop drinking alcohol. And the rule of thumb is sort of like, for every number of drinks that you had, you want to wait that many hours before you go to sleep, because that would give it enough time to metabolize. So, for example, if someone had 3 drinks, then you want to stay awake for about 3 hours before you actually fall asleep to have the lowest effect on your sleep health. And then in the evening hours, make sure that you create an environment of darkness so that your circadian rhythms of the night can be activated, your natural melatonin levels start rising, and it just becomes a very easier process to fall asleep. And then when you're in bed, make sure you have a cool, dark environment. And anywhere between 67 to 69 degrees Fahrenheit is typically what the academy recommends. Um, Sagar, I'm curious. I know we have an audience here, and the intention of this was to be more of an AMA, and would love to open it up for questions for uh, the audience that is here, and would love to be able to answer any questions that you guys may have.
Hello, I have a question. Very, very interesting take here. A lot of things that I did apply to the practice, and then it come up again to today's discussion, and it just reiterate, what I need to share with the patients. One of the things that interests me is the INAP. I never heard about that, and maybe you can talk more about it, and then the resources that I can see, what kind of indication for this INAP device. That's the first thing, and then number two, when you mentioned about hypnotic, I thought you know there is a way to hypnotize people. And all of a sudden you talk about medication. I was like, oh, okay. So that's how you call it, hypnotic medication. I never heard that term, but when you call benzo and Z, and then okay, so that's what you meant by hypnotic. I thought that hypnotic method to make you sleepy or something like that. So those are my two inputs and question. Thank you.
Yeah, no, thank you. I wish I had like the magic to to hypnotize somebody.
Right? I thought so. That would be interesting to know.
Yeah, and then record it into a sleep story, right? And just let it circulate at nighttime. Yeah, and then when in medicine, typically when we refer to hypnotics, we're referring to like sedatives and hypnotics, like that
Mm,
class of medications. Uh,
mm,
and when you were asking about the INAP, INAP stands for intermittent negative airway pressure. So CPAP is continuous positive airway pressure,
I
and it
see.
comes in different levels of either automatic or bi-level. And INAP is basically sort of a suctioning device for the oral pharynx.
I
It's
see.
like, and we can send you some information afterwards, but it's a
Yeah,
little mouthpiece that is connected with a straw-like extension to a negative pressure pump,
I
and
see.
it creates a pressure of somewhere between like I think 50 to 1 to 200 millimeters of mercury negative airway negative pressure,
I
and it's
see.
actually quite. It's almost like sucking a straw of like a shake of a vanilla shake. It's like just like that level of negative airway pressure,
Mm,
and it pulls the tongue anteriorly and forward.
mm,
By doing that, it if that seal is well enough, it creates more space in the back of the throat.
I
So
see.
it can work reasonably well. It's FDA approved for people who have for adults who have obstructive sleep apnea who can breathe through their nose. And that's like an easy way to think about it. So
Mm,
you want to make sure they don't have any central sleep apnea.
mm,
They don't have any nasal obstructions. But it is a therapy available,
mm,
and we have a couple of patients on it. For at least I can speak from my experience, it did not work as well as CPAP,
mm,
but the patients subjectively felt better with this than they did with CPAP
mm,
because there was less sort of obtrusiveness on their face. So it is a potential tool
mm.
um, that is available to patients.
Okay. Is it too intrusive to have oral device together with this INAP? I didn't see the picture of this, so would that be too interfering to patient to have both devices?
Yeah, I don't think one would be able to because a dental appliance, it does not give access to the tongue. And the way that this creates negative, the way it creates a seal is by connecting to the tongue. Um, so I don't think that one would be able to do both of those things at the same time.
Mhm. Okay.
Do
All right.
people wake up with a dry mouth after using this device?
No, in fact, people, whenever there is something in the mouth, the physiologic response is usually to hypersalivate.
Hmm.
And in fact, the suction, the tube, it comes out into a canister that collects the saliva for from overnight. And patients will typically, throw that out and rinse it. And that's the only thing that patients typically have to do with that device. But it's interesting. People have been very receptive to the idea of something less bulky and that could be therapeutic.
Mhm. So what are the indications to for this INAP?
Any degree of sleep apnea that is obstructive in nature,
Mhm.
that and the patient needs to be able to breathe through their nose. Those are the main indications where this can be considered.
Mhm. What happened, for instance, if somebody already did the nasal hygiene and then they was able to sleep, but naturally they have difficulty breathing to their nose, and then they put the nasal dilator, and then they use this device. Will that be an issue down in the night, where maybe the nose will plug up again and then this INAP is not going to work? So I'm talking maybe about the cuddle test. Now, if somebody has cuddle test positive, will this be something that cannot be prescribed?
Yeah, that's a good question. I don't, I think should be just considered on a case by case basis.
Okay.
Because sometimes, like I don't know if you've had this experience, but if you help someone breathe better through their nose, then they can breathe better through their nose during the night. But if that individual then stops breathing through their nose because their mouth opened, then the nose can become congested.
Yes.
So I think it just depends on that individual. But um, what I always tell people is, like, we don't know what's going to work until we try, and
Right.
let's try it and then see what happens.
Okay. All right. Thank you.
If there are any other questions, I would like to ask something. I was wondering if either of you doctors had a chance to work with ex-pro athletes, for example, regarding their sleep issues that they have. Sometimes I see professional athletes like a Baltimore Ravens center is about 320 pounds or so dying of sleep. Daryl Dawkins dying in his sleep. Moses Malone dying in his sleep. Have any of you ever had a chance to work with athletes like that, or ex-athletes like that? Why would they die suddenly in their sleep?
Yeah, Michael, I don't know if you want to take the first shot at this.
I have not. I mean, I've worked with former professional athletes, but sorry. The question is why would they die in their sleep? Like if they're very large.
They could die in their sleep. I was almost thinking, okay, because they would die because of sleep apnea. Okay. Or complications from sleep apnea. I'm wondering, have you come across anybody who's had sleep issues as being an ex-athlete, and how do they die when they're sleeping like that?
I mean, I don't think that you're at risk just being a former athlete. I think if you have untreated sleep apnea, certainly you're at increased risk for sudden cardiac death if you're not treated for sleep apnea. I think it's probably a multitude of reasons that, like, blood pressure is raised. I think the statistics are you're 4 times more likely to have a heart attack or a stroke if you're untreated for sleep apnea. So that would likely be the cause.
I see.
Dr. Chopra, do you have an input on that as well?
Yeah, no, like, I guess, like, the question was, like, this idea of, like, sudden cardiac death and, like, causes of sudden cardiac death that just happens to be in their sleep, right? I mean, sudden cardiac death could be during the day, or it could happen at night during the hours of sleep. And we're assuming that it's a sleep disorder that's driving it. But sudden cardiac death has a whole list of things that can be caused that can cause that. And, like, hypertrophic obstructive cardiomyopathy, like unknown cardiac issues could be one reason. But if someone is suspecting a sleep disorder that is causing someone to die in their sleep, then obstructive sleep apnea is the most obvious thing that comes to mind. But it's possible that central sleep apnea can also do that, especially if someone is not necessarily substantially overweight. And we know that the incidence and prevalence of sleep apnea, sleep disorder breathing is much higher in people who have large necks and have excessive chest body girth. And so their pulmonary physiology is different as compared to someone who's thin. So it's, I'm sure it's like, I'm sure it's a multitude of reasons, as Dr. Kagen was saying. But if someone does have that uh, physical appearance and they do have sleep apnea, the likelihood of dying is higher. Um, but like, you know, again, like knowing exactly what's driving it, that only like one would need to do a sleep test to make sure that they don't have at least sleep apnea. But there's many, I'm sure there's many things that can cause someone to pass away in their sleep.
Yeah. Maybe we can take one more question and then wrap up from there, if there is another question.
Yeah, no, absolutely. I have one last question. I would love to hear a little bit about YOMI. I forgot to ask you that, and I was just reminded right now. Would love to hear a little about the, you had talked about um, early intervention using data, and you know, YOMI is a tool that you and your team have put together to help us with that. Would love to hear a little bit more about that.
Oh, perfect. Yeah. YOMI stands for Your Organized Medical Information. So it's essentially all of a person's health information in one place. And we've made it very easy so people can share their information with whoever they want to, whenever they want to. So it's truly like universal chart of all your information. And we're bringing in all of the wearable data into YOMI. So we have all of the wearable data and essentially like all of your health data just in one place so you can monitor it. And the goal really is to, for most use cases, it's maximizing productivity, whether you're in a boardroom or you're on an Olympic stage. It's allowing us to detect early signs of overtraining or early signs of illness and be able to assess people's full health. So we take a holistic picture. We're looking at sleep is certainly a large component of what we're looking at, but we're looking at all of someone's health and saying, how can we maximize your productivity and help you live a healthier life?
Got it. And who purchases it? Is it like the doctor purchases it for their patients, or does the patient say, "Hey, I want all of this information to be consolidated for me. I want to come and be a YOMI user." How does that typically work?
Yeah, so in our current state right now, we're only licensing to teams, so athletic teams, but membership medicine teams as well, and potentially academic teams as well. So as an individual user, you have to be a part of a team that uses YOMI. So the team is mostly responsible for organizing the data and working in a collaborative effort with members of any kind of team to better health together.
Got it. It's super interesting. I'm curious, have you had any unique insights when you put together data of their, say, CGM and data from a wearable and data from the medications that they're on and the number of steps that they're walking and all of it, when you have like all of this data coming into one place, I would imagine that one can develop a whole bunch of unique insights. I'm curious to hear like if you've had some sort of like magical moment when you saw all of this come together in a way.
I mean, there's specific metrics that we're looking at, but a lot of it is members of my practice will have all this data from their wearables, and they just don't know what's important and what part of the data they should be looking at and paying attention to. So it's really like personalizing for every individual what, based on what their goals are, of what data points we should be looking at and following those trends over time to make improvements.
Any specific like data point that you've, or data trend of a physiologic parameter that you found like the most useful so far?
I mean, certainly basic vital signs like temperature data and heart rate data are very, very helpful, especially for early signs of illness. If you think about someone contracting influenza, you can detect that very, very quickly on wearable devices. And oftentimes, the windows for treatment is very small for viral illnesses. You need to act quickly. So having the team alerted to this so that it's not all on the individual to report it to their physician, that's very, very helpful for maximizing not just that individual's productivity, but the entire team.
Yeah, so that's Fascinating. If someone wanted to learn more, what would be the best way for them to learn more or contact you?
They can get in contact with us through yomihealth.com, YOMI health.com.
So, no, definitely. We'll definitely share the message of a place that helps you consolidate and understand your data and track it over time. That's super interesting. And just to validate that, I saw a patient I think a week ago, and she had done a few nights of sleep testing um 6 months ago. So we had some like baseline data of her sleep health, and it fit the picture of mild sleep apnea and good sleep quality. And she came back to us and we retested her again, and those metrics were substantially higher.
Mhm.
And we had to figure out like what's going on. And what we learned was that she now had allergies, and these allergies were driving difficulty with breathing during sleep. But I would not have even asked the question like what's changed here if I did not have the historic data. So I can totally see how having longitudinal data like this can be super formative.
Absolutely.
Um, Thank you, Dr. Kagen, for your time today, sharing with us how to look at sleep in a membership-based practice. You help shed some light on uh, data when it comes to one's individual in their individual health data that has been sort of put together in an organized way. And we look forward to keep working together and helping people improve their sleep. Take care. Bye-bye.
Excellent. Thank you for your help.
Thank you.
Thank you.